Welcome to session 5 of the Simple course. Having suicidal thoughts is, for many people, a serious hole. Crisis plans can be an essential tool for working with the whole of having suicidal thoughts. In the first part of the session today, we will continue to review distress tolerance skills. In the second part, we will talk about suicidal thoughts and how to use crisis plans and distress tolerance skills to work with them. To watch our introductory video entitled 12 Cognitive Biases Explained, please pause this video now and open session 5 on the website itsimple2021.com. This video complements our last session in which we briefly surveyed aspects of philosophy and considered how we come to have the beliefs that we do. Next are our usual reminders directed mostly at participants doing the course in a group setting. Please take a few moments to read these on your own. To watch this week's mindfulness practice video, please go to the website now. For people doing the YouTube course as part of a group, you can now pause for questions, comments, or feedback. Let's go over what we will do today. We will start by reviewing the skills training workbook, pages 14 to 32. Then we will talk about self-harm and suicidality and how to use crisis plans to deal with those. This will be followed by a break, and then time for questions, comments, reflection, and discussion. At this time, please rate your homework and write a number 0 to 10 at the back of your notebook next to the date. Remember, this is for your eyes only and to help you to relate your progress to the effort you're putting into the material in the course. In the first part of today's session, we will continue reviewing the stress tolerance skills. This section of the skills training workbook that we're reviewing today covers 3 topics or groups of skills. 1, Calm Mind Accepts, which is an acronym for distracting from emotional mind, with A for activities, C for contributions, C for comparisons, E with emotions, P with pushing away, T with thoughts, and S with sensations. Number 2, soothe yourself with the 5 senses. And number 3, create a distraction and self-soothing plan, meaning choose skills to use in your crisis plan. In 2 weeks, we will discuss advanced distress tolerance skills. And the acronym is IMPROVE, the moment, with I for imagery, M for meaning, P for prayer, R for relaxation, O for one thing at a time, V for vacation, and E for encouragement. In 4 weeks, we will look at the physiological hacks to calm yourself, and the acronym there is TIP. T for temperature, I for intense exercise, and P, progressive muscle relaxation. To watch a video about self-soothing skills, please pause this video now and go to the website. As part of the homework for the last week, we asked you to read pages 14 to 32 of the Dialectical Behavioral Therapy Skills Workbook, 2nd edition. In what follows, we will cover the key points from this section of the workbook. This summary is not meant to replace you having read these pages in the workbook and try the exercises. This section of the workbook covers 4 distress tolerance subjects. 1. Radical acceptance. 2. Distraction. 3. How to relax and self-soothe. And 4. How to create a relaxation plan. Radical acceptance is a Buddhist concept. Dukkha is Buddhism's first noble truth. It says that pain is inevitable. What is somewhat under our control is what we do with that pain. One thing most of us do is resist it. One way of resisting pain is by judging it, as we do when we decide it's bad, wish it was over, or believe that we can't tolerate it. Pain, when met with resistance, results in heightened distress and is called suffering. Although very few people like to be in pain, if we are in pain, another option open to us is to simply observe the sensations that we call pain without judging them and accept that they are what they are, relaxing into them without resistance. This has been proven to lessen distress and suffering. When we encourage you to do this, we are not suggesting that pain is a good thing. We are simply rationally focusing on what we can do about it to make it more tolerable. Radical acceptance coping statements are wise mind statements that help us switch from seeing our pain from a judgmental, emotional mind resisting perspective to a rational and wise mind accepting perspective. Some radical acceptance statements include, this is the way it has to be, it is what it is, I can't change what's already happened, it's no use fighting the past, this moment is the result of 1 million other decisions. You can find other examples of radical acceptance coping statements in the skills training workbook. As you start practicing radical acceptance, start small. For example, use radical acceptance coping statements when you're in a long lineup at the grocery store or caught in heavy traffic. Prepare these statements beforehand so that you are ready to use them when you need them. Practice using them in your imagination before you do it in real life. The second set of skills covered in this section of the workbook is how to distract yourself from self-destructive behaviors. Remember that your self-destructive behaviors are very likely maladaptive attempts to cope with your pain. Although these behaviors may bring temporary relief, over the long run, they only further damage you physically and psychologically. Examples of self-destructive behaviors or maladaptive coping mechanisms include abusing substances, gambling, disordered eating, lashing out at others, self-harm, etc. These maladaptive coping mechanisms may become routine or part of your coping repertoire and may be difficult to stop or change. Plan a less dangerous activity for the next time you have an urge to carry these out. For example, if you feel like self-harming, hold an ice cube in your hand instead, or snap a band around your wrist. Think about your maladaptive coping mechanisms and write them down. Then come up with less damaging or dangerous alternatives. Practice these in your imagination using the edit, splice, and paste technique, and paste them into situations you have already lived through, and use the maladaptive skills. View the new, more adaptive coping video repeatedly in your imagination. Another way to distract yourself from the distress that can lead to self-destructive behavior is to distract yourself with pleasurable activities. Pages 18 to 20 of the workbook list many different pleasurable activities. Pick a few that appeal to you. Consider using these as part of your crisis plan. Use the edit, splice, paste technique to practice them in your imagination. Paste them into a situation you have already experienced. Engage in these activities often. Don't wait until you're distressed. Pleasurable activities are not the only way to distract yourself. Some suggestions of how to distract yourself offered in the workbook are: distract yourself by counting numbers, focus on your breath, or ground yourself in your environment. Focus on someone else. Pay attention to them. Do something nice for them. Think of someone you care about. Distract yourself with thoughts. Remember past pleasant events. Observe nature. Imagine your wildest fantasy coming true. What would that be? Distract yourself with tasks or chores. Take care of yourself or your environment. Distract yourself by leaving a situation. Sometimes it's helpful just to leave and create some distance between you and the problem. The workbook offers so many different distraction techniques that you might become overwhelmed and not use any of them. Take some time after the session today to pick one or two distraction techniques that appeal to you. Practice those. If you find they're not working well for you, go back to the skills diary card and pick different ones and practice those. In this way, you will be creating your own individualized distraction plan that you can use with your simple tools such as the crisis plan. The third skill set covered in this section of the workbook is learning to relax and soothe yourself. To be relaxed, you have to be in the window of tolerance, that is, in calm or alert. You soothe yourself by doing something that calms you down and brings you back to the window of tolerance. One good way to soothe yourself is through your senses. Sensory information can rev you up, such as when you do a highly stimulating activity, for example, going to a rock concert or watching a movie that keeps you on the edge of your seat. Sensory information can also calm you down. There are activities that involve the five senses that tend to be calming for most people. The following slides offer some examples. Soothe yourself through your sense of smell. Burn candles, incense, wear perfume or essential oils. Go to a place with a comforting smell. Bake. Go outdoors. Soothe yourself using vision. Make a collage. Find a picture or place that's visually soothing. Carry a photo of someone you admire. Soothe yourself using sound. Listen to music. Listen to audiobooks or a podcast. Listen to nature sounds. Use a white noise machine. Meditate. Soothe yourself using taste. Eat your favorite meal. Eat comfort food. Try some cold or hot drinks. Gum, mints, or candy. Put ice cubes in your mouth. Drink fresh juice. Soothe yourself using touch. Carry something soft and comforting in your pocket. Take a warm or cold shower. Get a massage. Play with a pet. Wear comfortable clothes. Today, we reviewed radical acceptance of distress, distraction from self-destructive behaviors, and learning to relax and soothe yourself. The skills training workbook offers you many different possible strategies or skills for accomplishing these things. Having such a wide choice can be overwhelming. Pick one or two strategies from each of the three categories. Write these down and stick with them for a while by practicing them. Remember that these skills are meant to be used in your crisis plan or to deal with times when you find yourself in a hole. Practice the skills for holes you've been in the past using the editing, splicing, and pasting technique. Stay in the window of tolerance by pendulating as you're doing this. Today, we're going to talk about suicide. Is there a risk that some people might be triggered by this discussion? That's a very good point. Discussing suicidality can trigger memories of personal experiences that people have had with it. It's very important in every session, but especially in this one, that people keep monitoring their personal dashboards. If your crisis risk increases or you find yourself very outside the window of tolerance, you should pause and use your distress tolerance skills. Hopefully by this point, you have picked a few to use on such an occasion. Although there is some risk of triggering people, this is an important discussion to have, and provided people are careful, I think the benefits of having it outweigh the risks. Many people attending the simple course may never have experienced suicidal ideation. Suicidal ideation is, however, a common and very important hole that some people encounter. Because it can be so catastrophic, we address it in this session. Some people who struggle with mental health issues have either occasional, frequent, or constant suicidal ideation. Suicidal feelings, including despair and hopelessness, and suicidal thoughts and behaviors, are for anyone who experiences them a critical whole for which crisis plans and distress tolerance skills are necessary. Although this discussion may trigger some people, it is an important one to have at this point in the course. As we proceed today, pay attention to your internal dashboard and take care of yourself the best you know how. Take a break if you need to. When talking about suicide, there are many different terms that are used. Having all of these terms can be confusing. Would it be useful to define some of them? This is a partial list defining some of the most frequently used terms when people talk about suicidality. Suicidal behavior is any behavior resulting in an attempt or preparation for an attempt. This may include practicing or rehearsing for the attempt. Suicide attempt is a non-fatal, self-directed, potentially injurious behavior with any intent to die as a result of the behavior. A suicide attempt may or may not result in injury. Non-suicidal self-injury is a deliberate directed destruction or alteration of body tissues without a conscious suicidal intent. Postvention are interventions to address the care of bereaved survivors, caregivers, and healthcare providers. These are meant to destigmatize the tragedy of suicide and assist with the recovery process, also to serve as a secondary prevention effort to minimize the risk of subsequent suicides due to complicated grief, contagion, or unresolved trauma. Suicide contagion is the phenomenon by which suicide and suicidal behavior increase for some who are exposed to the suicide of others. Suicide plan is how and the means by which the person intends to carry out suicide. Suicidal intent refers to the main goal or objective of the suicidal behavior. Is it seeking relief, sending a message? Is it a cry for help, an expression of anger? Suicide-related communication conveys to others the suicidal ideation. Suicidal threats, an interpersonal communication that a reasonable person would interpret as communicating or suggesting that suicidal behavior might occur in the near future. And suicidal gesture, suicide-related behaviors that are carried out without suicidal intent. It's a term that can be misused to convey an intent to manipulate. Where does suicide rank as a cause of death in Canada? Let's look at some statistics. In Canada, there are approximately 4,000 suicides per year. That's an average of more than 10 every day. Every person's suicide profoundly affects an average of 10 people. In Canada, there are approximately 120,000 suicide attempts every year. That's over 300 every day. More than 90% of people who attempt or complete suicide have diagnosable mental health issues. More than half of people who complete suicide have never received any kind of mental health care. Males account for 75% of completed suicides. Females account for the majority of suicide attempts and self-harm. Overall, suicide is the 9th leading cause of death in Canada. However, for people aged 10 to 44, it is the 2nd leading cause of death. Are suicide and self-harm different? Yes, let's first consider self-harm and then talk about the differences between self-harm and suicide attempts. It's important to distinguish self-harm from suicide attempts. Self-harm is also referred to as non-suicidal self-injury. Self-harm is defined as the deliberate hurting of the body, such as by cutting, headbanging, hitting, or burning. Self-harm is a harmful and maladaptive way of trying to cope with emotional pain, such as frustration or anger. There are differences between self-harm and suicide attempts in terms of frequency, method, severity, and purpose. There are several important differences between self-harm and suicide attempts. Self-harm attempts are relatively frequent, whereas suicide attempts happen much less frequently. Self-harm involves cutting, burning, and self-hitting. The most common form of suicide attempt is by overdosing. Self-harm attempts are in general less severe. Suicide attempts are more severe and sometimes lethal. Self-harm is done to avoid suicidal impulses. Suicide attempts are carried out with an intent to die. How do mental health professionals approach their work with people who have suicidal ideation? A good assessment is the first step of an intervention with a person with suicidal ideation. A good assessment should consider several factors. There are usually two steps to an assessment: a screening and a risk assessment. Screening usually happens before a more in-depth assessment. The screening determines whether that in-depth assessment needs to be done. On the left-hand side of this slide is a typical screening tool. The assessment itself is often divided into 5 steps. 1, identifying risk factors in the person. 2, identifying protective factors. 3, doing a suicide inquiry. 4, determining the risk level and the appropriate intervention. And 5, documenting all this information. There are established protocols for assessing people with suicidal ideation. Let's start by discussing the first step of the assessment: determining risk factors. In epidemiology, a risk factor is a variable associated with an increased risk of a disease or a negative health outcome. Suicide risk factors can be divided into the chronic and the acute. Risk factors for suicide have been well researched. Chronic risk factors that predict suicide over the long term include previous suicide attempts, history of suicidal thoughts and behaviors, history of mental health issues, history of psychosis, impulsive or aggressive tendencies, history of self-harm, chronic illness and pain, family history of mental health issues, family history of suicide, history of family loss, history of abuse, neglect, trauma, cultural risk groups, male gender, LGBTQ populations. Acute risk factors that predict suicide over the short term include current suicidal thoughts, current suicidal plans, recent suicidal thoughts and behaviors, access to suicidal methods, increased non-suicidal self-injury, current mental health issues, current psychosis, agitation and anxiety, current substance use, feelings of hopelessness, recent loss or major life events, recent suicide in the family or community, minimal social supports, minimal professional supports, minimal supports for the caregiver. Risk factors help assess the likelihood that a person will complete suicide and are an important part of the suicide assessment. People with acute high risk are those who are most often admitted to hospital. People with chronic high risk and or low acute risk factors are most often treated in outpatient settings and are sometimes denied hospitalization. Another consideration in the assessment of suicidal risk is determining the chronicity and lethality of the suicide method. Lethality of method refers to the percentage of people who die in suicide attempts with a particular method of suicide. Acuity and chronicity of suicidality refers to how long or frequently the person has thought of suicide. Individuals with suicidal ideas can be roughly grouped into 4 categories. 1, those with a highly lethal method and a chronic pattern of suicidal ideation. 2, those with a highly lethal method in whom suicidal ideation is a new phenomenon. 3, those with a low lethality method and a chronic pattern. 4, those with low lethality in whom suicidal ideation is new. Treatment approaches vary depending on which of these 4 categories people fall into. The risk level for suicide is often rated on a spectrum from no risk to imminent risk for completion. Progressively increasing degrees of risk are described as 1, suicidal thoughts without suicidal intent; 2, suicidal thoughts with passive intent; 3, suicidal thoughts with active intent; and 4, suicidal thoughts with a specific plan. Intent means the determination to do something. There are suggested guidelines for dealing with each of these different degrees of risk. In real life, the fewer resources that there are, the more mental health professionals develop a tolerance for suicide risk. Risk assessment is an important part of working with people with suicidal thoughts. What happens once that risk assessment is done? There are three types of approaches to working with people with suicidal ideation: suicide intervention, suicide prevention, and building resilience. One, suicide interventions describe the recommended steps to take with someone who has suicidal ideation. Two, suicide prevention is the collection of efforts to reduce the long-term risk of suicide of individuals and communities and societies. Three, building resilience involves helping vulnerable people develop ways of adapting in the face of adversity and distress. The distress tolerance skills in the crisis plan are interventions and prevention strategies. The overall goal of the simple course is to build resilience. Suicide intervention is what is done in an acute situation when an individual has suicidal thoughts and is at risk of carrying them through into action. This 5-point crisis plan is a generic crisis approach to work with people with suicidal ideas. The individual crisis plans that we work on in the simple course are specific to each individual. This generic crisis plan involves 5 steps. 1, knowing the warning signs and precipitants of suicidal ideation. 2, securing or removing lethal agents. 3, individual coping. 4, interpersonal coping. And 5, professionals who can help. I encourage you to go to the website and look over this crisis plan. Note, however, the many points of overlap with the crisis plans we prepare in the simple course. Take the time to consider this simple crisis plan. If you have suicidal thoughts, it's important that you prepare a crisis plan for that specific whole. A crisis plan is a suicide intervention tool that should be prepared when a person is not in an acute crisis. For people who are in acute crisis and don't have a crisis plan, working on one with a mental health professional is an important intervention. Such crisis plans should be concrete and follow a template, not vague and undocumented. To do effective suicide intervention, professionals have to be proficient at doing several things with clients. The professional has a clear model for their intervention. They build trust with clients. They are transparent with clients. They coordinate with other professionals. They do psychoeducation. They accept that they have limits, as do systems. They manage expectations. They have healthy boundaries. They are consistent. They collaborate with clients. So far, we talked about suicide intervention. Suicide prevention refers to the collection of efforts aiming to reduce the long-term risk of suicide of individuals and in communities and societies. Suicide prevention strategies are studied by sociologists and implemented by public health and government policy. They include strengthening economic supports, increasing mental health resources, creating protective environments, promoting connectedness between people, teaching coping and problem-solving skills, identifying and supporting people at risk, and lessening harms and preventing future risk. Dialectical behavioral therapy was originally conceived as an approach to working with people who self-harm and have suicidal thoughts. How does DBT approach that work, and is DBT an effective strategy? DBT introduced a number of novel suicide intervention and prevention strategies to support its overall aim of helping people to increase their resilience. These strategies include: 1, the concept of patient-professional partnership, which contrasts with the medical model of the professional taking charge and making decisions for the person who has suicidal ideas. The emphasis in DBT is on helping the person develop and implement a crisis plan rather than having the professional take control and be the person's safety plan. 2, the avoidance of involuntary commitment, which is seen as toxic to the therapeutic partnership. 3, the emphasis on building a life worth living as the best safeguard to suicide. 4, placing the therapeutic emphasis on prevention and intervention and not resorting to hospitalizations after an attempt because at that point the person's already chosen a solution to their distress. 5, making continuing in therapy contingent on the success of that therapy, as evidenced by a reduction in self-harm and suicidality. Improvement in these areas is a prerequisite for the yearly DBT therapeutic contracts to be renewed. 6, the use of mutually pre-agreed yearly number of respite days in a safe professional environment. The patient chooses when to access these days, but the total number cannot be exceeded. The graph on the left of the slide compares individual and group supportive therapy with dialectical behavioral therapy over a period of 12 months. In both groups, there is a significant decrease in self-harm episodes. The decrease is greater in the DBT therapy patients. The graph on the top right compares general psychiatric management to dialectical behavioral therapy. There is a reduction in the frequency of suicidal episodes in both groups over a period of a year. The difference between the general psychiatric management and DBT is not significant. The graph on the bottom right compares the frequency of non-suicidal self-injurious episodes. Here, over the course of 12 months, there is a significant difference between the two groups, with the DBT patients doing better. Do you have any tips for someone who has suicidal ideation and has to resort to professional help? To improve your chances of accessing appropriate and helpful professional resources, consider the following. 1, get to know the crisis resources available in your area. It may be easier to get the help you need from someone you already know and trust. 2, have a crisis plan ready. 3, when possible, share that crisis plan with the professionals you are seeking help from. If possible, before the crisis. If not, during the crisis. 4, work out beforehand what help you need from professionals by specifying it in your crisis plan. 5, use assertiveness scripts to ask for specific forms of help. These scripts will be covered in the interpersonal effectiveness module of this course. 6, ask if the hospital or professional you work with uses hospitalization contracts. 7, use the edit, splice, and paste technique to work with a past crisis in which you access professional help to rehearse more effective approaches in case they are needed in the future. Keep in mind that while all mental health professionals would ideally be understanding, sometimes we can also be judgmental. In a previous session, we described the steps involved in preparing a crisis plan. Today, using Anne as an example, we will illustrate how that's done. Anne, as with all other clients presented in this manual, is not a real person, but rather the composite of many real people. I've tried to make these cases as realistic as possible. Anne was raised by a perfectionistic and critical single mother who spent long hours at work managing a restaurant. Anne told her therapist that she had felt sad and lonely for as long as she could remember. She had a few romantic relationships, but they always ended up with her getting hurt, and she had long ago decided she was better off living alone with her 3 cats. Anne, now in her late 50s, had for the last 25 years been a nurse in a family-run Mennonite nursing home. For the last 15 years, she had been the staff manager. Her job was the highlight of her otherwise quiet life, and she considered her patients her family. Anne embraced the nursing home's commitment to making the residents' last years as meaningful as possible. She was rewarded with the residents' great appreciation. Anne was also like a daughter to the elderly couple, Ezra and Ruth, who owned and ran the home. They did not think of the home as a business, but as a service to the residents and their employees. With the support of this work family, Anne managed her low-grade chronic depression and anxiety well, never missing a day of work. When Ezra began to show signs of dementia, Anne was devastated. Ruth and Ezra continued to run the home as long as they could, while looking for a new owner who would carry on with their philosophy of care. Eventually, unable to wait any longer, they reluctantly sold to a company that ran nursing homes all over the province. This transition was extremely difficult for Anne, and her anxiety and depression worsened. A new general manager, Jane, took over the home and was tasked by the new owners with introducing the company's policies and procedures. As Anne was the nurse in charge, she was required to meet with Jane once a week to report on the staff's progress with the transition. Although Jane was always pleasant and polite, it was clear to Anne that the nursing home would be run very differently and that the financial bottom line had become an important consideration. Anne started seeing her psychiatrist more often during this trying time. Together, they tweaked her medications, but that seemed to be of limited help. Anne did not feel she had many options. She could not see herself in her late 50s finding another job and could not afford to retire. If she went on disability, she would leave her beloved patients and was afraid she'd become even more withdrawn and depressed. She and her psychiatrist concluded that although this was a stressful and challenging situation, Anne's dysregulated emotions contributed significantly to her symptoms. They decided that the current acute hole within Anne's longer term chronic valley was anticipating a meeting with Jane every week. They decided to work on a crisis plan. In one of the sessions with her psychiatrist, Anne worked on a crisis prevention plan for the hole she fell into just before her weekly meetings with Jane. Working with the crisis plan template, Anne recognized that her unhelpful behavior was that although she forced herself to attend these meetings, she wanted to run away from them. And after the meetings, she withdrew from her usual activities and ruminated. She was triggered by this work situation because she felt she had no control and felt pressured and devalued. The warning signs that she was in a hole were that she would eat more, cry, ruminate, be unable to sleep, isolate herself, and avoid people. Being alone made it worse. People may fall into holes at unpredictable times, in which case it is crucial to be aware of the warning signs and triggers so that people do not miss the fact that they are in a hole. Anne's patterns were much more predictable. Although she also ruminated during the remainder of the week, she felt the greatest distress the day before her meetings with Jane. She felt some relief after the meetings when her worst fears had not materialized. Being aware of this pattern was helpful in implementing the crisis plan. As Anne reviewed the distress tolerance module in the skills training workbook, she thought that distraction, self-soothing, and self-care would be good skills to use when she began to ruminate about work. She decided that the most helpful skills to deal with this hole itself might be radical acceptance, practiced relaxation, commitment to value action, and using coping thoughts and strategies. Anne had previously taken a cognitive behavioral therapy course and was familiar with thought records. It seemed to her that the DBT's coping thoughts were similar, if less structured than thought records. She was good at doing thought records and decided to structure her crisis plans around one. The situation was that the nursing home had new owners, and she had to meet weekly with Jane, the manager. Her feelings around this were anxiety and sadness. Her automatic thoughts were, I won't be able to cope, working at the nursing home won't be the same, it will be awful, and I will lose my job and income and I'll be poor. The facts that supported her automatic thoughts were she did struggle to cope sometimes and was vulnerable. The new company that had taken over the nursing home did not care about her in the way Ezra and Ruth did. To this company, nursing homes were a business and making money was important. If she did lose her job, she would be in financial distress. The facts that did not support her automatic thoughts were Anne was often told she was an excellent nurse and had coped with many difficult situations at work before. Jane had told her that she and her new employers valued her experience and familiarity with the residents. They knew she was part of what made this nursing home special, wanted to keep that quality, and would work with her to do that, while at the same time introducing some changes. Anne had done some research and knew the company had a good reputation and ran the other nursing homes well. She also realized that poverty was a long way away and that she had many options before she got to that point. For the evidence for her automatic thoughts and the evidence against her automatic thoughts, Anne came up with a balanced perspective. Her DBT's coping thoughts were, although she was struggling, she had coped and adapted to many challenges before this. Although this was a change, the company had a good reputation and wanted to keep her, the staff, and the residents happy and wanted to work with her. Anne also realized that her fear of authority figures and of people in general had to do with the relationship she had had as a child with her mother. Jane was not like her mother, and so far had been kind and respectful to her. Working through the thought record, Anne was reassured and slightly surprised by how much calmer and more confident she felt by the end of the session with her psychiatrist. She also decided to commit to valued action by frequently reminding herself that succeeding at her job was not just about her. She owed it to Ezra, Ruth, and to the residents. This was her purpose in life. She was good at it and was proving to her mother that she was not worthless like she had always been made to feel. Succeeding at this new challenge would help her to heal from her traumatic childhood. Anne had shared her struggles with Ruth and told her about the crisis plan. Ruth suggested she come to their house weekly for supper, the day before her meeting with Jane, and agreed to spend some time helping Anne focus on her principles and goals. Anne also resolved that she would devote 20 minutes every evening to visualizing herself in wise mind, knowing her strengths and what was important, working with Jane, so that the nursing home would continue to serve the residents while maintaining high staff morale. While doing the visualization, she would be mindful of her activation and breath to ensure she remained in the window of emotional tolerance. Anne is still working at the nursing home. She gained confidence from having managed the transition successfully and is given a lot of autonomy by Jane and the new company's management. If you're doing the Symbol course as part of a group and at any point would like to work with us during the session on a crisis plan or any other tool, please let us know. This is the homework for the coming week. On the PowerPoint presentation that you will find on the website, there are a series of slides that will help you review the strategies, techniques, and tools that we have previously covered. Looking over these slides will help you to consolidate the material. Thank you for being with me today and see you next session.